Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department at Nassau Community College, along with nursing student Gina Peter. And today is a show for ladies in our audience because we're talking about frequently asked questions that you may be embarrassed to ask your OBGYN. Our guest today is Dr. Jane Minkin, Clinical Professor of Obstetrics and Gynecology at Yale University. Dr. Minkin, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Well, thank you very much, Dean, for asking me to be with you. It's a pleasure to be here.
Likewise. First of all, I hope you're doing well. And
I trust you personally.
How are you personally during COVID, this pandemic?
Well,
how have you been faring?
I think I'm hanging in there pretty well.
Yeah.
I'm very fortunate that my patients are lovely patients I'm privileged to take care of. And everybody's been very good about being okay about coming in to visit with masks and social distancing and things like that. And obviously during a pelvic, that's hard to do. But we try to do everything else with the appropriate things. And, and obviously we're here to take care of our patients. So, that, it's been fine. And, so you don't go too far afield, but, that's fine.
Yeah.
So what made you want to become an OBGYN? Can you tell us a little bit about your professional career?
Oh, sure. Absolutely. Well, I'm old, so that's just so I've been doing this for a while, and things may be a little bit different when I started than when they are right now for young people considering the field. But I think the basic reasons are still the same. I went into medicine because I like being with people. I like taking care of folks. I like chatting with folks, listening to folks. And so that's number one. I also love science. And I thought that medicine was a good place to, take science to dealing with people. That's sort of the way to combine the two. And as far as going into OBGYN as a specialty within medicine, I thought as a woman I might have a little bit of better understanding of women's issues perhaps, although I take care of guy patients too, it's okay. When I started off, I was in internal medicine doing an internship, so we took care of guys too. And the other thing that's really nice about obstetrics and gynecology is that with gynecology, you get to do a lot of diagnostic work. You do well patient care, annual visits, primary care. We investigate problems, hormonal problems, other issues. And then if we have something that comes up that requires surgical intervention, we can then go ahead and do the surgery. So it's a combination that we could not only, diagnose things, but then treat the patient. And if they need medications, we take care of them that way. If they need surgery, we take care of them that way. And then, of course, the whole other issue is obstetrics, which is a blast. That obstetrics, you get two patients for one. Basically, you take care of the mom and you take care of the baby inside. And sometimes that can be challenging. Mm-hmm. And so that makes it, obviously you have to deal well with both of them.
Let's first talk about fertility, because I know that you were quoted as saying it's misunderstood among young women as there are many factors involved. So can you please explain a little bit more about that?
Well, one of the questions that I get asked regularly is there a test for fertility? Do I know that I, as a woman, whatever age, am going to be able to get pregnant and have a baby? And the answer is, unfortunately, the only true test of fertility is actually getting pregnant. Now, we can investigate the issues that contribute to women, couples not getting pregnant. We certainly can do that. But there's no, the only true test of getting pregnant is getting pregnant. Shall I talk about how we basically go about evaluating a couple that comes in for an infertility?
Absolutely.
Let's talk a little bit about definitions first, because what constitutes fertility, And if a couple comes to me and says, we've been trying to get pregnant this month, we tried and it didn't happen, I would say, well, that's too bad. But indeed, that statistically, if a couple really tries to get pregnant, having intercourse, every other day around ovulation time, only 15 to 20% of those folks are going to be pregnant by the end of 1 month. Okay. By the end of 6 months of trying, 50% of the couples will be pregnant. By the end of a year of trying, 80% will be. Okay. So it may take several months, may take a year for couples to really achieve pregnancy, or even longer than a year. We also factor into that some age issues. Okay. Because what my usual advice to a couple who's trying to get pregnant, I say, you can try to help, plot out the times you're most likely to get pregnant around ovulation time, for example, and we can talk about that. But if you are trying to get pregnant for about 6 months and you are over the age of 35 or older, I usually say that's a good time to let us start doing some investigations of why aren't you conceiving, even though there's very good chances the couple will conceive in the ensuing 6 months. But we start doing some simple testing to say, okay, why isn't this working for you? Okay. If the woman is younger than 35, okay, the guy can be a little bit older, but if a woman is under the age of 35, we usually advise keep trying for about a year, because there's really good odds that you're going to get pregnant. Okay, now there are simple tests one can do to start looking for reasons things might not be happening, but we encourage people to wait a little bit longer and give it a little bit longer to happen without too much interventions.
What would be some direct lifestyle habits that I could do if I wanted to become, if you will, more fertile?
Certainly, there are things that women and guys can do on their own, too. For women, one of the major issues that many people are not aware of is being as close to your ideal body weight as possible is helpful for fertility. So people who are way underweight, women who are way underweight, if they've had eating disorders or things like that, or if a woman is significantly overweight, that can hinder her fertility, her getting pregnant. And the way that works is that women who are way underweight or way overweight don't ovulate as well. Okay, and you need to ripen up an egg and release an egg to get pregnant. So if you say, I want to optimize my chances that way, try to get as close to your ideal body weight as possible. Okay. In the previous life, okay, as far as that's one thing to say, okay, let's focus on right now. A general health habit for women to do forever, okay, is to protect themselves from sexually transmitted diseases. Okay. So that's why I always encourage condoms. I give lots of lectures, and I always say during my lectures, if it's a contraception lecture or sexuality lecture, did I mention the word condom in the last 5 minutes? Well, let me just say it a few times, because the key thing is sexually transmitted diseases, particularly chlamydia and gonorrhea, can really compromise fertility, because if one gets an infection up inside the uterus and the fallopian tubes related to chlamydia or gonorrhea, that can cause scarring of the fallopian tubes, and that will keep the sperm and the egg from meeting together. So you want to minimize your chances of getting a sexually transmitted disease and getting so-called pelvic inflammatory disease. So that's just a general health style for your whole sexual life before you decide you want to get pregnant. That's a good thing to be doing. Okay. So those are things. As far as other habits, for guys, believe it or not, that if a guy drinks a lot of alcohol, okay, he's heavily drinking alcohol, that may compromise his function of making sperm. So we would encourage guys to, it's good general health not to drink too much alcohol, but that it really can compromise sperm activity and sperm making. So we would encourage that. And of course, for a woman who's wanting to get pregnant, it may not influence her fertility so much, but we really don't want women drinking during pregnancy. Mm-hmm. So when you're trying to get pregnant, it's a good time to say, okay, let me give up that, that wine or that beer or that alcohol that I'm drinking, because I don't want to be doing that while I'm pregnant. Okay, so those are things. It may not have too much of an influence on fertility, but it's not good to do that while you're pregnant. So it's a good health habit to get into.
So when is it that you're too old to get pregnant?
If you look at statistics, and many, many women, unfortunately, these days are not ready to get pregnant at our most fertile times. Okay. Yeah, if you can get pregnant before you're 30, that's great. You're probably most fertile then, but many women haven't finished school. They, have other responsibilities. They want to get going with their jobs, appropriately so. So they want to delay things a bit. Up until about 35, there really isn't a significant drop off to fertility. Okay. Once you get into the 35 to 40 range, there is a moderate drop off in fertility. Once you get beyond 40, things can be a little dicier as far as, just actual fertility numbers. And then, and this is going to sound crazy, but even 40 to 42, there's a significant drop off. So, and once you get to beyond 42, I won't say people don't get pregnant, but it becomes trickier. Okay. And the problem is just biologically is we are born with all the eggs we're ever going to have. Okay. And once we start having periods, we go through puberty, our eggs start ripening up every month, and we just keep losing eggs over the course of time. There are less and less, fewer and fewer eggs present for us to be able to, to have a baby. And our eggs are getting older as we get older.
So what happens to the eggs as we get older?
Basically, the eggs don't function as well. Okay, they don't respond as well to the stimuli to mature and to start making the hormones necessary for pregnancy. And so sometimes it's like kicking the tires on a car. They need a little more of a kick to get them going, that sort of thing. So again, the eggs are just getting older as we get older. Now, again, I just want to caution people, that doesn't mean you can't get pregnant. And I personally have delivered 3 women who were 47 at the time of delivery who were not infertility patients. These were pregnancies. So on the flip side of it, when I deal with my menopausal ladies, I can say, just because fertility may be somewhat diminished as we get older, it ain't zero. Right. So if you don't want to get pregnant, be using contraception until you're done with this menopause business. So that's the flip side.
Doctor, is fertility familial? In other words, if you have a mother or grandmother who's had children very late in life, is your predisposition to have children late in life also possible or more probable?
That's a good point. And indeed, that the age at menopause does tend to run in families, okay? And if somebody's having a kid later on in life, it means her ovaries are a little more robust and she's not going to go through menopause early. So and that does tend to be familial. So these women may have a little longer longevity in their fertility based on that sort of thing. Now,
I don't know if that's good news or bad news, but
it's news. It's news. We're all scientists, so we're interested in scientific accuracy. Now, the other thing to think about, though, in fertility stuff, is that, for example, endometriosis is an entity which can influence, and it's not a cancer or anything like that. I don't want people to get nervous about that. But it is a condition whereby the lining of the uterus sort of can plant outside the uterus, and it can influence fertility. And that does have some hereditary components. So if a mom has a history of endometriosis, her daughter may have a somewhat higher chance of having endometriosis, and that can have a problem with fertility. So there are some other side issues that can be contributed.
You're listening to Your Family's Health on the voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, along with Nassau Community College nursing student Gina Peter. And today we're talking about frequently asked questions that you may be embarrassed to ask your OBGYN. Our guest today is Dr. Mary Jane Minkin, clinical professor of obstetrics and gynecology at Yale University. So, doctor, you mentioned endometriosis. Is it true that it is a higher predisposition for African-American women to have fibroids and or endometriosis? And why would you say that is?
The answer is, one thing I can guarantee you is a free trip to Stockholm if you have the answer, because you will win a Nobel Prize. Because the answer is, I wish the heck we knew. Unfortunately, we don't. But we do know, unfortunately, that African-American women do have a significantly higher chance of getting fibroids. Now, what a fibroid is, again, this is a benign condition, but it's an exuberant growth of the muscle wall of the uterus. And unfortunately, it seems that for some reason, which we don't know, that African-American women have a higher burden of fibroids. Endometriosis is perhaps a little more common, but it's nowhere near the preponderance thing of seen in African American women, compared to Caucasian women. It's certainly a little bit more frequent, but not as pronounced as the fibroid issue.
How does the menstrual cycle play into fertility and getting pregnant?
Let's talk about a normal menstrual cycle. A normal menstrual cycle is composed of 2 parts, and it's simple to think about. It's just the beginning part is where the egg is ripening up. And that's called the follicular phase. And the area around the egg as it ripens is called the follicle. So it's the follicular phase. What happens is, as this follicle is really ripe, as the egg is really ripe and ready to go, the ovary gets a kick from the pituitary gland. I don't know if people on the radio can't see it. I'm pointing to my head, which is up in our heads. But we get a kick from our pituitary gland that says to the ovary, okay, release that egg. It's ready, go. So what happens is that egg is then popped out of the ovary, gets picked up by the fallopian tube, where it gets carried towards the uterus. Now, 2 things are going on at this point. this gets pretty intricate, is the area on the ovary from which the egg was released starts making a hormone called progesterone. Okay. And the progesterone is important because it helps prepare the lining of the uterus for the egg being fertilized and lets it implant into the wall of the uterus. Okay. And progesterone for pregnancy. So this progesterone starts being made by the ovary. And what's also the sort of, and we're all designed to have babies. That's what this whole system is. Let's get you having a baby. So if a sperm happens to travel up, or a bunch of sperm go inside the uterus, travel up to the fallopian tube and actually migrate into the fallopian tube where the sperm and the egg get together. That's called fertilization, okay, which actually takes place in the fallopian tube. Then this happy couple now travels down the fallopian tube into the uterus, plants itself in the wall of the uterus if this uterus has been prepared by this progesterone hormone for the happy couple arriving, and it starts developing. Okay. And that second part of the menstrual cycle is called the luteal phase, because the area in the ovary is called the corpus luteum, where all this progesterone action is taking place. Okay. Now, what happens in a menstrual cycle where the egg is not fertilized, okay, no sperm, or the sperm didn't get to the egg, that the egg then passes into the uterine cavity, and then the lining of the uterus sheds. You get a period. So, but the ovulation time is the crucial time for that sperm and that egg to get together and then travel down and implant into the wall of the uterus.
So this very intricate process, what would you say is the most common cause of infertility in terms of this whole? Right.
The answer is, how can I say everything? Okay.
Everything.
First of all, let me just divide it into male factor and female factor. About half the time, it's actually related to sperm. That there aren't happy sperm or wiggly sperm or enough sperm around and stuff like that. So there can be issues that, so we call male factor infertility. About half the time, and maybe a little less than half the time for male factor, and a little over half the time it's female factor. And there, the two most common issues are the egg not maturing right. In other words, basically ovulation issues, that the egg isn't being prepared, being released and stuff like that. Those are ovulation issues. And then another about half the time is that the tubes can be blocked. And they can be blocked from scarring from, as I mentioned before, PID, pelvic inflammatory disease. It can be blocked by endometriosis, can cause scarring in the fallopian tubes. There are things, for example, if a woman had appendicitis as a kid, she had a bad attack of appendicitis and it left some scarring in her pelvis. Even things like that can be factors. So that those are all factors that can contribute to the tubes not being open to let the sperm and the egg get together. And then there are some little bit less common factors. For example, the sperm, which are deposited into the vagina, have to get up into the uterus, and they have to travel through the cervix. And the fluid that lines the cervix, people call it cervical mucus, sometimes can be hostile to the sperm. That the sperm don't like the mucus. So you have to have happy sperm and cervical mucus to get up inside too. So those are also factors that can be at play. Now, there are some things that we can do along those lines. For example, if for the cervical mucus thing, one thing that can happen to couples if they're trying to really time intercourse to say, okay, I know I'm ovulating. Okay, we'll talk about that in 1 minute. I know I'm ovulating. Now's the time to have sex to maximize my chances of getting pregnant. But having sex on demand sometimes can be tough. It's like, okay, it's 12 o'clock on Tuesday and we have to have sex, stuff like that. It's like, okay, that's not really romantic. So the woman may be dry, for example. And the problem is if she's dry, they may need to use a lubricant. Okay. And what's interesting is lubricants are not all created equal. Some lubricants do not make sperm happy. That they can actually be toxic to sperm. So if somebody is having a problem, needs some lubricant, and she's trying to get pregnant, we usually encourage people to use a sperm-friendly lubricant. And the one we usually recommend is something called Pre-Seed. That's Preseed, just as it sounds. And that is actually makes for happier sperm. So where
do I get Pre-Seed? Where do I get that from?
Get it at the pharmacy. You can order it online, or you can get it, that's over the counter. You don't need a special prescription or anything like that.
And why does the sperm like that particular lubricant?
Couple of things. Basically, it's the concentration, as far as the electrolytes in it and stuff like that. And so it's equal to the sperm as far as equal to the seminal fluid. It's not going to be toxic as far as its concentration of different electrolytes and stuff like that. And it also does not hinder sperm motility. It's a nice viscosity so that the guys can swim. We want swimming guys in there.
So for couples that are trying, what should they look for in tests?
pregnancy tests are not all the same. I mean, same thing like the lubricants aren't all the same. With a pregnancy test, now, of course, you're talking to an old woman here, because when I was a little girl, we actually truly had to wait for the rabbit to die to see if somebody was pregnant. So the tests we have, the stuff that's available now is just, to me, miraculous that we can do these things. And the thought of being able to do a test at home really started blowing my mind when these things came on the market, with the advances that have been made truly in the last 40 years or so. So basically, there's accuracy of tests, and what the tests rely on, what the urine pregnancy tests rely on, is the concentration of a hormone that is made by the placenta, developing placenta, where that sperm and the egg got together, planted in the wall of the uterus and to the lining of the uterus, and that it starts dividing and it starts making these hormones called HCG, or human chorionic gonadotropin, fancy label there, but that HCG, and that's what the tests are measuring, the urinary tests. And different tests have different that turn positive at different concentrations of the HCG hormone. So the more accurate the test can detect the lowest levels of HCG. And actually, there are tests on the market these days, which again astounds me as an old person, that you can, because you can actually tell you're pregnant 6 days before the first day of your missed period.
Wow.
Which it's like a week plus after you get pregnant, which to me is amazing. And that test, for example, the first response folks have a test that is that sensitive, and you can buy it at CVS, Duane Reade, whatever, that it's over the counter. You can do it at home, and you can know you're pregnant 6 days before you miss your period.
How if I'm anticipating starting a family as a woman, and I wanted to know how fertile I am, is there any way that I can determine that in going into my planning for family?
Sure. One test that you can do, and that's what I said, there are some tests that you can do which can give you an indication of what's going on. Of course, it may not give you the absolute, you're going to get pregnant. Well, you can actually test for ovulation. Okay, which is another advance over the last 30 years. That people, can actually find out, are they ovulating and when are they ovulating? And what you're measuring there, is I mentioned something about a hormone that kicks the ovary to get the egg out, the so-called, and that's called LH, or luteinizing hormone. You get a surge of LH right around ovulation. And you can actually measure the LH concentration in urine, which says, okay, LH is coming up, we're going to ovulate, now's a really great time to have sex. So you can actually do an ovulation predictor kit at home. First response people make that, some other tests on the market. There's an accurate test. So you can say, okay, am I ovulating? So for example, if you did that test, and most people ovulate around mid-cycle. If you have a 28-day cycle, you're probably ovulating around day 14, day 15, somewhere in there. Counting your first day of your period is day 1. That's day 1 for you. So basically, you can see, am I ovulating? So let's say you did an ovulation predictor kit. You tried several of those sticks and didn't look like you're ovulating. Okay, try it again next month. So if you say, gee, it doesn't look like I'm ovulating at all, then it's time to talk to your healthcare provider, your gynecologist, nurse, midwife, whoever, and say, it looks like I'm not ovulating. What's going on? And you can evaluate that.
How has the COVID-19 pandemic affected fertility rates, or has it at all?
Well, it has somewhat, we think. There's not a huge amount of statistics out there yet because, of course, we started seeing, COVID back in March, really, in significant numbers. And so we don't have definitive data. It does seem that people because again, all this is based on lack of knowledge, to be honest. We don't have a ton of data. From what we've seen with COVID, although yes, can a baby be born with COVID to a COVID positive mom? Yeah, but we haven't seen anywhere near the problems with babies, for example, as we see with Zika, for example. Zika is a terrible virus that seems to affect the babies, significantly. Whereas with COVID, it's not an entity like the Zika virus. But babies can be born sick, but fortunately, in general, are not. We are seeing a slight increase, it seems, of women being put into intensive care units who actually come down and get sick with COVID. However, that partially could be because we're being just more cautious with them. When somebody's pregnant, you want to take extra good care of them. So we may be have a lower threshold for putting somebody in an ICU to monitor her breathing and things like that. But we have not seen an increase in mortality, fortunately, or things like that, which is great. But again, this is a lot of unknowns. This is emerging data. Case reports keep coming out now. So what we've seen is that a lot of couples are saying, okay, if I am young, young. If somebody's 30, and to me that's very young, and says, we'd like to have a kid this year, but if we had a kid next year, that would be okay too. Okay, fine, that's great. And that we'll have a lot more data for people as far as saying, yeah, now, we know what happens to pregnant ladies. We have a lot more, information on that. If a woman's 42 and she's saying, I think I'm going to have a baby now, I really wouldn't want to push her to say, oh, let's just wait a year or two, because she's in that crucial point we talked about as far as saying, don't have a lot of time to really wait on that.
Do you see patients, or are most OBGYN still seeing patients, and how has this affected your practice?
We are seeing patients regularly, and indeed, with my practice, that, as I said, most of my patients are very good about masks and social distancing and things like that, but we kept seeing patients, pregnant women in our office from all the way through, because a baby's a baby, and, people are pregnant, we have to take care of them. We did certain things a little bit differently. I will say we did that. For example, you won't see waiting rooms full of people in OB as the office these days. I mean, we try to make sure that people, come into a room. We don't have people sitting in a waiting area being exposed to other folks. That's one thing we do. In the old days prior to February, March, we would always love to have older siblings come to a pregnancy visit, because we like to involve older siblings. It's nice for them to hear the baby's heartbeat, to see where the baby is, how mom's doing, and stuff like that. We unfortunately could not have a lot of folks. And so, we couldn't have partners coming in because we were really trying to keep people isolated. So it's nice to have a partner with you. Well, we couldn't do that, and so that, we were restricting number of visitors, things like that. So that affected care somewhat. But as far as the actual care of the woman during pregnancy, medically, it was very similar. It really hadn't changed dramatically. And the other thing is, we did find, for example, that some of the OB visits we had weren't necessarily in-person visits that people had to have. So we would do a little bit of telehealth visiting, as opposed to hands-on visiting. But of course, hands-on visiting you have to do. So we, bring people in to measure them and hear the baby and check the baby's, kicking and things like that we couldn't do long distance.
When should we have our first mammogram?
Excellent question. The answer is, I don't know. There are a whole bunch of different guidelines out there as far as recommendations. Okay. For example, one question that I always ask if I'm seeing a new person, well, let's talk about family history. Okay. If mom had breast cancer at a very young age, I am certainly going to have that young woman come in early. Okay. And of course, we'll talk about genetic family histories and things like that. But if a woman's just, no family history, no special risks or anything like that, we tend to start people at about age 40, as far as coming in for mammograms. There are some guidelines that say don't do it until 50. We, in general, don't necessarily hold to that, but there are sets of guidelines that you can see out there that will say don't do it until 50. We tend to start at 40.
If one of our friends listening wanted to get in touch with you for more information about questions they may have, how can they get in touch with you? Do you have a website?
Okay. Unfortunately, my website is very bad as far as being able, it's not terribly responsive. You can look at it. My exciting website is madameovary.com, and there's a lot of information.
Oh, I like that.
But as far as getting in more information about fertility and things like that, there are several good sites for fertility. Firstresponse.com is a good website. It's an excellent website with information about fertility and the different products that are out there and how to use these tests. The other website that's very good as far as pregnancy planning information, March of Dimes, has a lot of pregnancy planning information. And of course, the other website that's out there, particularly for issues involving COVID, the American College of OBGYNs has a lot of information. It's ACOG.org.
Thank you so much for being here, Dr. Mary Jane Minkin, Clinical Professor of Obstetrics and Gynecology at Yale University. We hope you stay safe and continue the great work that you do.
Thank you very much. Happy to be with you.
This is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, along with nursing student Gina Peter. And we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.